I think we're going to get started with our next session. If people can make their way in, that would be great. Okay, good afternoon, everyone. Thank you so much for joining us. It's about that time to start our afternoon session. My name is Amit Grover. I'm one of the pediatric gastroenterologists at Boston Children's Hospital. And I have my colleague here, Mustafa. Why don't you introduce yourself?
Hi, my name is Mustafa, and I'm a gastroenterologist at Advent Health in Orlando.
Thank you so much for coming for this session today that we are entitling, or that has been entitled Chronic Pancreatitis, Current Guidelines and Standards of Care. We have an excellent lineup. And we'll start off with our first speaker, Mustafa.
Yes, we have with us Dr. Diraj Yadav, who really does not need any introduction. He's a professor of medicine at University of Pittsburgh and eminent sort of personality in the field. We look forward to Diraj's topic, which is long-term prognosis of chronic pancreatitis.
Thank you, Mustafa. This session is titled Chronic Pancreatitis Current Guidelines and Standards of Care. And my assignment is to talk about long-term prognosis of chronic pancreatitis. This is a very broad topic. I'll touch only on some aspects of it, specifically with an eye to the future. So for any chronic disorder, when we think about long-term prognosis, there are two considerations. One is overall survival, and second is disease-related morbidity. In terms of overall survival for chronic pancreatitis, several studies have documented that the overall survival in patients with CP is lower as compared to expected in the general population of same age and sex. What you see here in the graph is one example of a population in Olmsted County, where after the diagnosis of CP, the median survival was around 12.5 years, and the mortality was about 2 times greater as compared to expected. Couple of other important things here are to note is that most of these patients, or when we think about survival, we focus on patients who have alcoholic pancreatitis or late onset idiopathic disease, and not much attention to those who have early onset disease. Secondly, most patients with chronic pancreatitis, they die with chronic pancreatitis, then from chronic pancreatitis, with 75% mortality from other causes. When we think of early term or long-term survival in patients who have early onset disease, these are data from 2 studies. In the left panel is a study from Denmark, where patients who are diagnosed between 1980 to 2004 and followed till 2008. If you look at the Kaplan-Meier curve, the median survival is well over 20 years, even in patients who had alcoholic pancreatitis. But specifically in non-alcoholic pancreatitis, the median survival is much greater than that. Secondly, in the right panel is data from PRSS1 patients, symptomatic and asymptomatic, enrolled from the University of Pittsburgh over 20 years, where the expected survival is very similar to the general population. The importance of this is that patients who have early onset disease, in these patients, morbidity related to chronic pancreatitis is extremely important and a focus for us to think about. When we think about morbidity in chronic pancreatitis, again, numerous studies have documented that, and this is data from patients who are enrolled from UPMC in the NAPS2 study. Abdominal pain being most common, present in 90% patients, even at a median follow-up of about 12 years from onset of initial pancreatitis, about half of these patients continue to have pain, very high use of narcotic medications, high number of pancreatitis-related admissions, diabetes, exocrine insufficiency, and about 2/3 patients need some form of intervention during their clinical course. So if we have to think about improving long-term prognosis in CP, what are the strategies that we can think about? The first is to address the comorbidities, because that's the most important reason for overall mortality. But this is something that is outside the realm of us as gastroenterologists or pancreatologists. This is for the primary care physician and specialists who are seeing the patients for other reasons. As pancreatologists and gastroenterologists, we can focus on behavior modifications when it is indicated and think about pancreatitis-related outcomes that we can focus on. And the graph on the right side shows that as compared to what the expected outcomes on for these patients should be, our aim is to have desired outcomes, which is lower than what it is in a population of patients. So how do we do that? When I think about this specific situation, I can think of 2 different ways we can address it. One is by increasing awareness of healthcare professionals for best practices in longitudinal care of patients. This is an area that actually does not apply only to CP, it applies to all chronic disorders. Because many primary care physicians and GI physicians even, they are not aware of what the expected clinical course of these patients would be, and also what is the rationale for us in making clinical decisions. And this is important. And many of these questions, specifically for increasing awareness, very difficult to test empirically. Second is to optimize treatment for pancreatitis-related outcomes. And we can do that by integrating new discoveries into management algorithms and developing therapies to favorably alter the natural course of disease. This last particular topic is something that we feel is very difficult because we don't have any treatments at this time. But for us to put our thoughts together in this area is very important, because once we are able to conceptualize what the expected outcome will be in a group of patients and predict it, that will allow us to think about how we can improve it going forward. And I'll give some examples. So this is an example from a study from the Dutch Pancreatitis Study Group, where they looked at a subset of patients who are enrolled in the care cohort, and they looked at the records of patients to see how often the UEG guidelines for non-invasive management was followed in these patients. And on an average, each subject was eligible for about 26 guidelines. And what they found is that guidelines were followed in only 53% of patients. And this was not affected by age of the patient, sex of the patient, etiology of the disease, or the setting in which the patient was seen. So again, there's a huge margin for us to do better for the things we already know that are helpful for patients. Giving you some examples, this was a very nice study from Spain where they followed patients, 430 patients with chronic pancreatitis for an average of 10 years. And what they found is that patients who had exocrine insufficiency, the mortality in these patients was twice as compared to patients who did not have exocrine insufficiency. That's highly important after controlling for age, demographic, other demographic factors, etiologies, and other comorbidities. And why is this important? We looked at data in a national claims database in the United States, and we found that among patients who have chronic pancreatitis diagnosis, less than 10% get tested for exocrine insufficiency. The rate for PERT prescription is only in 1/3 of patients. And very importantly, of the patients who receive PERT, only 1/3 got appropriate dosing for PERT. So there is a huge margin for us for improvement. Another example that is in context to today's discussion is osteopathy. And these are the first data that has been published from the longitudinal cohort study Proceed from the CPDPC consortium, headed by Phil Hart and Darwin Conwell, who led this project. Among the 282 patients with CP in this study who underwent a DEXA scan either clinically or for research purposes, the prevalence of osteopathy was 56%. And if you look at the figure on the right, in men, we don't even think about osteopathy, but 40% men with CP had osteopathy, 12% had osteoporosis. And even in subjects who are less than 40 years, 30% of them had osteopathy. Why is it important in the context that I'm talking about? Because low BMI was the single most important reason or association for osteopathy with an odds ratio of 7. The second way to think about it is to incorporate new knowledge. And this is example from a study for a 3-center collaboration, UPMC, Johns Hopkins, and Aalborg University. In 171 patients with standardized measures, we assessed for prevalence of anxiety and depression. The psychological comorbidities were present in about 50% patients. And patients who had severe pain or constant pain had even higher prevalence than the other patients. And as you can see on the radar plot on the right, patients who had psychological comorbidities had lower quality of life in pretty much every domain. What is the implication of that? While we can always discuss about the cause and effect phenomena, the implication is if a patient with chronic pancreatitis has psychological comorbidities, adjunctive treatments could actually be beneficial in addition to the standard treatment that you're giving for pain. And one example of this would be cognitive behavioral therapy. So this is again a study from the CPDPC consortium that was led by Dr. Tanya Palermo from University of Washington. Patients who had suspected or definite CP who had pain, they were assigned to internet-delivered CBT versus usual treatment. And patients who received CBT, they had significant reduction in pain, more than 30% or more than 50%. And these promising results have now led to development of a larger definitive study. Now moving on to pancreatitis-related outcomes, this is a conceptual framework called Holistic Prevention of Pancreatitis Model. It organizes chronic pancreatitis into stages where we can start thinking about ways for primary prevention, secondary prevention, and tertiary prevention of disease. For chronic pancreatitis, primary prevention will be preventing progression from AP or RAP to CP. Secondary prevention would be slowing CP progression, and tertiary prevention will be to prevent progression to sequela of CP. Now, there are many ongoing natural history studies in CP, 2 from the CPDPC consortium, 1 in adults called Proceed, and 1 in pediatric patients called Inspire 2. The Dutch pancreatitis study group has the CARE cohort, and the Danish group has the PenFib study. And then a unique study called POST that is led by Manila Bellin is patients who have had TPIAT, an observational study for longitudinal outcomes. A few words about the PROCEED study. This is the first longitudinal cohort study in the United States, which organizes a cohort of patients using the mechanistic definition of chronic pancreatitis from normal to suspected CP and definite CP. We are in the 5th year of the study, And we have enrolled around 88% of the cohort and established a biorepository. What we are conceptualizing is that we'll be able to do cross-sectional analyses for different stages of disease in a variety of ways, and then do longitudinal evaluation of these patients over time. In context of today's discussion, this could allow us to develop new models for assessing disease progression that could be beneficial going forward. So to summarize, overall survival in CP patients is decreased as compared to background population. CP is associated with high morbidity. There are several strategies that we can use to improve long-term prognosis in patients with CP. And the ongoing cohort studies will inform the development of new models to monitor disease progression. Thank you.
Thank you, Dheeraj. That was an excellent talk. We are going to hold questions until the end when we'll have the panel come up. It gives me great pleasure to introduce our next speaker, also who actually doesn't need any introduction at all, is Dr. Roger Little, is a professor of medicine at Duke University and former president of the APA. And he will be speaking to us entitled Update on the Pathogenesis of CP.
Great, thank you very much. I wanted to make just a few observations this afternoon about the pathogenesis of chronic pancreatitis. How do I advance? Top green. Okay. All right, thank you. So the three major causes of chronic pancreatitis are shown here, and unfortunately, alcohol remains the most common cause of chronic pancreatitis. I'd like to introduce the idea, though, that duct obstruction, pancreatic obstruction, plays a major role in the pathogenesis of multiple forms of chronic pancreatitis. And we've learned a tremendous amount about the biology of chronic pancreatitis through genetics discoveries. And I'll use some of those as an example for exploring these topics. Chronic pancreatitis arises from primary damage to the acinar cell. And this can occur through a number of direct ways in which there may be physical damage, there may be oxidant stress, there can be mitochondrial dysfunction, and I think mitochondrial dysfunction plays a primary role. And we talked about, well, Peter Hegge mentioned that in his talk earlier today. And then there are calcium overload has been well described, particularly by David Crittle's group, and the role of alcohol in calcium overload, ER stress, defective autophagy, abnormalities in pancreatic enzyme secretion, and protease activation, and Miklos discussed this very nicely yesterday. Now, there are indirect mechanisms, and by that I mean primary duct problems, such as duct obstruction, alterations in pancreatic fluid pH or fluid volume. And then, of course, there's an inflammatory response, and this may be instrumental in, say, autoimmune pancreatitis. And the other major cell type in the pancreas, other than exocrine cell type, besides acinar cells and duct cells, of course, is the pancreatic stellate cell. And this is the cell that's responsible for pancreatic fibrosis. And the quiescent stellate cell is activated through a number of mechanisms, including cytokines that may be released locally, including TNF alpha, again, oxidant stress, and ethanol metabolites. So the genetic mutations that we have learned a lot about are briefly summarized here, and this is not an exhaustive list, but simply as an example. But mutations in the cationic trypsinogen gene, SPINK, the trypsin inhibitor gene, chymotrypsin C, all have implications for primary roles affecting protease activation. And that has been complemented by subsequent studies characterizing, say, CFTR, which is responsible for a good percentage of patients with idiopathic chronic pancreatitis, and the calcium sensing receptor which have primary abnormalities exhibited on the duct cell of the pancreas, and this can result in reduced fluid secretion, the impairment in acidification of pancreatic juice, as well as protein precipitates that may contribute to duct obstruction. Of course, carboxypeptidase A has been implicated in ER stress. Claudin has been implicated in a primary effect on the inflammatory cell. Now, if we look at alcohol as the major cause of chronic pancreatitis, it's almost overwhelming when you look at the potential mechanisms whereby alcohol can affect the pancreas. And this some of these effects are mediated by alcohol metabolites, such as acetaldehyde. David Criddle and the Liverpool group has done an outstanding job in characterizing fatty acid ethyl esters as a primary mechanism for inducing calcium overload that contributes to pancreatitis. And so these are, again, mechanisms that may affect directly on the acinar cell, but they also have effects on the duct cell. So alcoholic pancreatitis patients have an increased concentration of protein in their pancreatic duct, which may contribute to pancreatic duct obstruction. And there are alcohol metabolites that directly affect pancreatic stellate cells and can lead to stellate cell activation and subsequent fibrosis. So I have been struck for a long time by the observation that it's extremely difficult to produce pancreatitis in an animal by feeding that animal alcohol. So alcohol alone rarely, unless you do something quite extraordinary, does not cause pancreatitis. This is an example of feeding alcohol to mice who has a perfectly normal appearing pancreas. However, this may be modified by manipulating the diet. And we observe that putting animals on a low phosphate diet that in and of itself does not affect the pancreas. It certainly does not cause pancreatitis, even though it lowers serum phosphate levels. When you add alcohol to animals on a low phosphate diet, they get a resulting pancreatitis that's manifest by all of the typical features of pancreatitis that we normally expect to see, with pancreatic edema, elevations in pancreatic enzymes, neutrophil infiltration, and obvious changes in histology. Now, this is due to the low phosphate concentration, in that it can be reversed by treating animals replacing them with phosphate. And so putting animals on a low phosphate diet, adding alcohol causes pancreatitis, and this can be prevented by administration of phosphate, and it lowers all of the parameters that we would normally see. We think this occurs through effects on mitochondrial function and generation of ATP. So animals on a normal phosphate diet treated with ethanol maintain good mitochondrial function. This is manifest by maintaining their mitochondrial membrane potential. However, when they are on a low phosphate diet plus alcohol, the mitochondria lose their ability to generate ATP. And again, this can be restored by adding back phosphate. And here is the ATP content in the pancreas in animals on a low phosphate diet with and without alcohol. And this can be restored by restoring ATP levels by replacing phosphate. The other point that I want to make is that looking at the morphological features of chronic pancreatitis of various etiologies, and here I've thrown in even tropical pancreatitis, autoimmune pancreatitis, and other idiopathic causes of pancreatitis. If one looks at the pancreatic duct, they are abnormal. They either have subtle irregularities or stenosis or frank dilation. Now you may say, well, that's simply a result of their pancreatitis, and that may indeed be the case. but I would suggest that perhaps the pancreatic duct abnormalities may contribute to ongoing pancreatitis. And of course, all of these causes of pancreatitis are associated with pancreatic fibrosis. So I'll just conclude by introducing the concept that perhaps that duct obstruction contributes to pancreatic pathology, and it may occur through the force that's exerted through duct obstruction. And that can be either small duct obstruction or large duct obstruction. So we've had the opportunity to investigate this. It came about by trying to understand how the pancreas was so sensitive to pressure. And we identified that the mechanically active ion channel piezo is the most abundant mechanoreceptor in the pancreas. This is a very large membrane protein. It's 2,400 amino acids, and it possesses this 3-blade-like structure that floats in the plasma membrane, and it's a cation permeable channel. So that activation of the channel by deforming the plasma membrane can open the channel that is primarily permeable to calcium ions and has the ability to increase intracellular calcium concentrations. And I'm not going to show you those data because Sandeep Swain in our group is going to be presenting an abstract in the session immediately following this one, and he will explain how this may contribute to chronic pancreatitis. So I've tried to provide just a few insights into the pathobiology of chronic pancreatitis, and I would suggest that central to these mechanisms in many causes of pancreatitis is not only going to be the contributions of duct obstruction and pressure, the genetic manifestations, and alcohol itself seem to be mediated in large part by abnormalities in mitochondrial dysfunction. And I would suggest that might be a strategy for attacking multiple abnormalities that occur as a result of multiple different insults. In maintaining the energy sources within the acinar cell may be a strategy for at least preserving some remaining acinar cell function, regardless of when and how pancreatitis begins. So thank you very much. I appreciate your attention.
Thank you, Dr. Little. Our next talk is actually a virtual talk by Dr. Rupchayoti Talukdar. He's a director of the Pancreatic Asian Institute of Gastroenterology in Hyderabad. He's also the director of the Pancreas Research Group there. So this will be a virtual talk, and we can get started on that.
A very good afternoon. At the outset, I'd like to thank Professor Saluja and the organizing team for this kind of invitation. In the next 12 to 13 minutes, I'll take you through some of the aspects of nutritional management of chronic pancreatitis. Now, let me begin with the story of baby Annie. She presented to our pancreas clinic in June 2012. And she had a diagnosis of chronic pancreatitis in 2010, but she had been suffering from the symptoms since 2 years earlier. Her BMI presentation was around 50, and she was deficient with several micronutrients, and cross-sectional imaging showed a little bit of pancreatic atrophy. The duct was 6 millimeter, while there were no stones within the pancreatic duct. She received treatment of pancreatic enzyme of 10,000 units after meals for the past 2 years, and she was on a fat-restricted diet. This is a prototype of chronic pancreatitis, and in this kind of a clinical scenario, pancreatic enzymes are usually started as if in a reflex manner. The golden rule of the term for pancreatic enzyme replacement therapy is it's used in the right timing, the right preparation, and the right dose. So when I talk about right timing, there are a few studies that have shown equal efficacy if the enzyme, whether the enzymes are used along with food, before food, or just after food. But in clinical practice, what we see is the patient is most compliant if they take the enzyme preparation along with food. And this is important because it's essential for the enzyme preparation to be delivered in the duodenum along with the food chain for proper mixing and optimal action. And to put it, microsphere or mini microsphere is the right preparation because the enteric coating is important for protection of the enzyme from gastric acid degradation. And the microsphere or mini microsphere, by virtue of its size of 2 millimeter or less, enables the passage of the enzyme through the fibroid channel along the food chain. But the most contentious question is the right dosage. And I think we still do not know the accurate dose and the right method to figure out what doses the patient will require. And there are several ways that can be done. One of them is to use the pancreatic physiology. So the daily pancreatic lipase output is around 600,000 units, out of which 10% is required for digestion. So that makes the daily requirement of pancreatic lipase of 60,000 units that can be split into different dosage. With that logic, starting dose of 25,000 to 40,000 units of lipase per meal appears reasonable. The recent European guidelines have recommended 36,000 to 50,000 units of lipase per meal and half the dose with a snack. And the even more recent ACG guidelines recommend 40,000 to 50,000 units of lipase per meal. And the other way of looking at it is in a per kg body weight manner, in which 500 units of lipase per kg body weight along with meals can be prescribed, and half the dose can be prescribed with snacks. But if we look at pancreatic enzyme replacement therapy closely, there appears to be several problems. Most of the studies test this enzyme replacement against a fixed calculated dose of fat diet of 100 grams of fat per day. But in the real world, usually patients with chronic pancreatitis won't take 100 grams of fatty diet per day. Most of these studies evaluate the non-clinical outcomes like the coefficient of fat absorption, coefficient of nitrogen absorption. And most of the studies are having a very short follow-up, on average of 2 months. There are 2 studies actually which had extended the follow-up to 6 months, and they also looked at some of the nutritional parameters, but a careful look at the study shows that these were industry-sponsored studies, and it appears that the sponsors were involved in the data analysis and paper writing. So I think the data from these studies needs to be revalidated in an independent manner. Till date, there are no studies that have evaluated the so-called entity of subclinical pancreatic exocrine insufficiency. And again, there are no studies that have evaluated the preventive role of PERT for the complications of the disease. And if we look at the results, they appear overall they appear variable across different studies. So if we consider this meta-analysis that was published in 2017, overall there was an improvement in fat and protein absorption. So most of the studies did not deal with the clinical outcomes. However, 2 more recent randomized controlled trials, one for post-operative patients undergoing Whipple's pancreatic duodenectomy, and the other for inoperable pancreatic cancer, the pancreatic enzyme replacement therapy failed to show any benefit in the nutritional parameters. And the final problem is the cost of this preparation, which is prohibitively high for a whole lot of patients, and in countries where insurance do not cover this enzyme, many patients end up being non-adherent to the treatment. Now, if we look at the pancreatic exocrine function, it is needless to say that pancreatic lipase is the single most important enzyme for dietary fat digestion. Even though there is an enzyme called the gastric lipase, this function of this is practically very minimal. However, for dietary starch digestion, it is the salivary amylase that plays a greater role than the pancreatic amylase. And for dietary protein digestion, along with pancreatic proteases, the gastric acid and intestinal proteases play an equally important role. So if a patient with chronic pancreatitis presents with protein calorie malnutrition, one has to consider that something beyond pancreatic enzyme replacement is going on. So let us see what happens in real life clinical practice. So this was a study that we have published recently where we enrolled nearly 500 patients with chronic pancreatitis. And we divided the patients into three groups, namely the group A had patients who took at least 25,000 units of enteric-coated lipase along with meals for at least 3 months. In group B, the patients were taking the enteric-coated lipase for at least 3 months, but they were non-compliant with respect to dose and duration. And patients in group C were either not started on PERT, and for those who initially were treated with PERT were eventually discontinued for over 3 months. And malnutrition was evaluated using the subjective global assessment. So if we look at the results, the proportion of patients who had malnutrition were similar irrespective of the status of intake of pancreatic enzyme supplementation. And the proportion of patients who were taking pancreatic enzyme replacement therapy was similar irrespective of the degree of malnutrition. Similarly, the proportion of patients who had weight gain or weight loss were similar irrespective of the status of pancreatic enzyme replacement therapy. So when we looked at the dietary intake, calorie deficit was similar for patients who were taking PERT compared to who were not taking PERT, but it was significantly low in patients who had malnutrition. Similarly, the dietary fat, protein, and carbohydrate intake was similar irrespective of the status of PERT, but was significantly low in the patients who had malnutrition. So when we looked at the possible risk factors using logistic regression, it turns out that the patients that low caloric intake and alcohol consumption were independent risk factors that were associated with persistence of malnutrition even after PERT. So even though pancreatic enzyme, pancreatic exocrine insufficiency and maldigestion are considered to be the major factor for malnutrition, it also appears that poor oral intake is also an equally important factor for malnutrition. And why do this patient eat less? One of the factors is that they are advised a fat-restricted diet, even though the guidelines do not recommend that. Many of these patients would not eat because of fear of pain. Chronic pancreatitis is associated with anxiety and depression, which could lead to poor oral intake. And of course, they have poor appetite, which results from inflammation, delayed gastric emptying, or substance use. And to top this up are the factors of the hypercatabolic state because of recurrent inflammation, presence of diabetes and the complications, neuropathy, and small intestinal bacterial overgrowth and oxidative stress. So all these factors as a composite would be responsible for malnutrition. Therefore, nutritional evaluation has to be done in a holistic manner using a multidisciplinary approach where the clinical, anthropometry, and biochemical assessment should be done. And also at some point in the disease course, sarcopenia and bone marrow density should be evaluated using DEXA scan and abdominal CT scans. Pancreatic enzymes are responsible for absorption of several micronutrients, but there are other micronutrients which do not require pancreatic enzyme for absorption and digestion. And moreover, several of the micronutrients gets used up in the oxidative stress of chronic pancreatitis. So even if the patient do not have overt pancreatic exocrine insufficiency, many of them could still have deficiencies of these micronutrients because of poor oral intake. So these has to be supplemented early on in the disease course. And this study from New Delhi had compared dietary counseling on normal home cooked food with dietary supplements, and it turned out that both of them are similar in improving the nutritional status of this patient. So here comes the importance of dietary counseling for this patient. So to summarize on how to improve nutrition in CP, the diet regimen should, for this patient, should be inclusive and not restrictive. A balanced, small volume, frequent feed is important, and more importantly, without fat restriction, especially if the patients are on enzyme replacement therapy. The diet regimen should be customized and personalized rather than using a diet based on a predetermined formula or a predetermined dose. If a patient is grossly malnourished and oral feeding do not reach the calorie requirement, they can be given a short course of mesovaginal feeding. Micronutrient supplementation, adequate glycemic control, cessation of substance use are important, and this patient should be counseled and educated every step regarding the nutritional management and disease management as a whole. So finally, coming back to baby Annie, so when she visited our pancreas clinic, we started her an antioxidant cocktail, nutritional supplement, and counseled her to take normal home cooked diet. And this is how she looked after 3 months. Her BMI increased to 20, and she did not have any fresh symptoms. So we stopped her pancreatic enzyme replacement at this point and continued the antioxidant cocktail and the home cooked diet. And she continued to improve in her nutritional status even without pancreatic enzyme, only on home cooked diet. And of course, in January 2015, she came back with pain. At that time, we detected stones in the main pancreatic duct, and she also had hypothyroidism. So we had to subject her to as well and treated her for the hypothyroidism. And this is how she looks now, without any gross symptoms. She's not on any pancreatic enzyme, not on any antioxidants. She's just on normal home cooked diet and has been taking thyroid replacement. So finally, I'd like to close my talk, and I'll be happy to take questions. Thank you.
Excellent. We will move on to our next speaker, who is Dr. Walter Park, who is the medical director of the Benign Pancreas Program at Stanford Healthcare. And his talk is entitled today, EUS in the Early Diagnosis of Chronic Pancreatitis. Are we ready for prime time?
Thank you. And it's a real pleasure to be invited to be a part of this symposium, particularly to share this podium with Diraj, Roger, and Roop, all people who I have a tremendous amount of respect for. So I've been assigned in the symposium under guidelines and standards of care to talk about EUS, and the title that was given to me was Ready for Prime Time. So there's already some implicit assumptions here, and even in the use of the title, suggesting that it isn't. And so I'm gonna basically make some assumptions about this audience as well, given the short time frame that this is a self-selected audience. You're obviously here, you're pancreatologists, many of you, you're familiar with the EUS literature. So I'm not gonna kind of delve into the basics of EUS and how it's used, but kind of go over where we are with the current guidelines and inject some of my thoughts about this discussion or this question of whether it's ready for prime time. For this particular talk, I have no relevant disclosures. So I think Diraj and Roger laid out nicely our paradigm that chronic pancreatitis is a progressive chronic inflammatory followed by fibrotic disease, and that there are significant complications as this disease progresses, including exocrine pancreatic insufficiency, diabetes, chronic pain, and in some cases, pancreatic ductal adenocarcinoma. And the idea or the assumption here is if we can detect it at an earlier stage, there may be opportunities to alter the natural history, these morbidities. And so again, this is the figure that starts with the general paradigm here is we have a normal pancreas. Over time, we have episodes of acute pancreatitis followed by recurrent acute pancreatitis, irregardless or independent of the etiology. And on the far right, you have essentially advanced chronic pancreatitis. And implicit in this concept is that there must be, if you assume linearity here, that there is a stage of early CP, early chronic pancreatitis. And then the question is, what does that look like? How do we know we have a patient with early CP? And I think that's really the essence of what we're trying to get for the purpose of having interventional strategies or to alter the natural history. And so on the top line is where is our current imaging in capturing this natural history? Well, we know that CTs are great at diagnosing calcifications and dilated ducts. But it's not accepted as a widely sensitive tool unless there's been further iterations perhaps in the future. We think that MRI and MRCP can do a better job, particularly looking at maybe Cambridge 1 or Cambridge 2 and capturing that, particularly its T2 MRCP signaling. Maybe with secretin function testing, we can, we kind of see it maybe as capturing a little bit earlier. And then the question is, where does EUS fit on this? And I think at one point, thought was in the concept of the controversial minimal change disease that perhaps EUS fits even earlier as the most sensitive test. So in this context, I'm going to kind of go over the guidelines. But before I do that, this is just a rehash of kind of what are those criteria of EUS features that we have correlated over time with chronic pancreatitis. And there are, as many of you know, parenchymal features and ductal features. And it should be, and I don't think there is data that does show that it correlates to histology. So when we do see hyperechoic foci or hyperechoic strands, it does correlate to focal fibrosis and bridging fibrosis or interlobular fibrosis. And this, again, is consistent with our models of inflammation followed by fibrosis. So in that sense, this has given rise to this would advocate for the idea that, with an EUS scope being the closest probe to the pancreas, giving the closest views, this in theory offers the most sensitive imaging and therefore has the greatest capacity to find early chronic pancreatitis should we see it. Okay, so with that kind of mindset, where do our guidelines sit? And so this is going to be just a brief walk kind of, in history. We go back to 2014, and these were the evidence-based statements about the role of EUS. And basically they said, okay, with these criteria, the ideal threshold, the number of EUS criteria necessary to diagnose CP has not been firmly established, but the presence of 5 or more or 2 or less strongly suggests or refutes the diagnosis of CP. And that the EUS features of CP are not necessarily pathologic and may occur as normal aging, as a normal variant, or due to non-pathological asymptomatic fibrosis in the absence of endocrine and exocrine dysfunction. These are basically quotes from the guidelines. And then in addition, the other Achilles heel is the poor inter-observer agreement for EUS CP features, which limits the diagnostic accuracy, the face validity, and the overall utility, therefore, of diagnosing CP by EUS. And the conclusion is that if you are going to use EUS findings, then you need to correlate it with clinical, structural, and functional analyses to make a possible diagnosis of early pancreatitis, chronic pancreatitis. 3 years later, the UEG did their own evidence-based consensus statement, and here they state statement 2.1, EUS and MRI and CT are the best imaging methods that we have for establishing the diagnosis, and that in statement 2.9, we've concluded that EUS is the most sensitive imaging technique for the diagnosis of CP, mainly during the early stages of the disease, and its specificity increases with increasingly diagnostic criteria. And when compared to histology, EUS has a sensitivity greater than 80% and a specificity of 100%. And there's excellent correlation between the number of EUS criteria present and CP severity with respect to histology. And these are the guidelines consensus from the Europeans. ACG 2020, basically, they take a slightly different bent. My colleagues, Tim and the authors say that we recommend CT or MRI for first line, and either test should be the first choice for the diagnosed CP, primarily because EUS is invasive And because it's lacking in specificity, it should be used only if the diagnosis in question after CT and MRI is performed. Not quite clear what in question they would pursue. But basically that they acknowledge from their review of the literature that EOS is comparable to MRI, CT in sensitivity and specificity of CP, and that it could be used if there is a concern for minimal change disease that cannot be seen by CT. But they also said that they, like the other guidelines, no specific criteria or number of criteria can be recommended at this time. Now, the Japanese diagnostic criteria in 2019, what I like about this particular criteria is that it actually attempts to go forward and come with some type of algorithm that does follow through on the sentiments of the APA guidelines of clinically correlating to morphology. And basically they have this algorithm that basically kind of, if you walk it down, you essentially have no signs of characteristic images of chronic pancreatitis. And then they say if you have these clinical features plus some of these EUS features are greater than 2 out of 4, including lobularity, hyperechoic foci or strands without shadowing, dilated side branches or hyperechoic MPD, then from a standardization perspective, we're going to make a claim that this is perhaps early CP for the purposes of consensus. Finally, given the numerous different guidelines across various different oceans, there was a consensus guideline from the IAP-APA, this very own organization, the EPC and the JPS in 2020 that basically said there was strong agreement. And this kind of goes back to the original APA guidelines that there is no ideal threshold. And they kind of take the same statement from the APA 2014 that you can't, that 5 or more or 2 or less is suggestive, respectively. They do make a comment that, yes, we acknowledge that there has been an attempt to standardize and weight certain features more than others through the Rosemont scoring. However, it has not appeared to demonstrate an overall improvement versus conventional scoring. And that, again, specificity, intra-observer variability, and pretest probability remain the Achilles heels for the utility of diagnosing EOS. So I think what I hope I've kind of conveyed to you at a high level is that no one really disputes that EOS is a sensitive modality, that it does potentially have a role, that it is widely used, but yes, it does have flaws and limitations like any diagnostic tool, in that there are patients who have morphological findings, maybe due to age or smoking, and in the absence of clinical correlating features, we're not sure what this really is, and maybe this is a pancreatopathy. I would submit that that's no different than even MRI and CT. For those of us in referral pancreas clinics, we get patients referred from outside doctors of a patient with a calcification, but no clinical history or risk factors of chronic pancreatitis. We could probably say the same thing. This patient doesn't have chronic pancreatitis because he doesn't have clinical symptoms. And this is maybe just a pancreatopathy. So the argument that the specificity limited by that doesn't dissuade me that EOS isn't ready for prime time. Perhaps the biggest thing is that EOS's major challenge is its inter-observer variability. Whereas with an MRI and a CT, you can take an image and you can share it around, and it's easily transmissible. So you can have many people look at it and agree or disagree on the quality and the morphology. Whereas up until now, we really had to take the EOS operator's word based on their report and based on those horrible looking little pictures. And I think, you know, if we borrow from our radiology colleagues in transabdominal ultrasound and that data is cheap, we really need to move, in order to move EOS further forward and make it a little bit more widely acceptable. And I think the biggest Achilles heel is the inter-observer variability. We need to be moving more towards video, standardizing video pictures of our EOS. Easy to save now, data is cheap. And I think as a consequence, we can then more routinely compare imaging studies and not just take other people's words or our fellow colleagues' words for it. So I think the question of is it ready for prime time? Well, I think it's a valuable tool. It's widely available. It does detect subtle changes. It's highly sensitive. It does correlate to histology. It has a lot of potential like MRI and CT and other modalities where we can use it as a platform to go beyond B mode. We can think about how do we use it in conjunction with tissue biopsies, elastography, contrast enhancement, and like all the imaging modalities, the role of AI. It is invasive. We do have to overcome this hurdle of high inter-observer variability, and cost might be an issue. And with that, I'll thank you for your time and attention, acknowledge my team. Thank you very much.
we could ask our speakers to join us on stage and we'll take some questions from the audience for a panel. Are we able to get our speaker from India on the Zoom?
Yeah, I'm here. I'm here.
Dr. Whitcomb.
So I really enjoyed this session a lot. I had a comment for Dr. Little's presentation, and then a question, a statement, and something else for Dr. Park. Back in the 90s, we did a number of studies on rats, giving them different levels of alcohol for different durations and those types of things. And then we did a type of transcriptomics called differential display to try to figure out what's going on. We were shocked, as you were, to find that in rats that drank high doses of alcohol, their pancreas appeared stone cold normal. However, on electron microscopy, it was obvious that the mitochondria were dilated and the cristae were broken and they were just in turmoil. But when you looked at the gene expression, the components to build new mitochondria were sky high, and it looked like there was a steady state where the mitochondria were being damaged and cleared out, but the rats were able to compensate for that by making mitochondria fast enough to maintain their function. So it's really interesting how much the body can compensate for injuries until key pieces are missing, maybe phosphates and others, and then it can't. So I've been thinking about this for quite a while.
Yeah, no, that's a very interesting observation. I suspect that that's right. We're sort of at a threshold between not getting pancreatitis and getting pancreatitis in heavy alcohol users. Yeah, that's very interesting.
My statement and question for Dr. Park relates to one of the papers that Dr. Yadav wrote with me. We were in an international sword fight and bloodbath about how to not only diagnose early chronic pancreatitis, but how to define it. And the problem is that EUS can identify abnormalities, but you have to understand the biology that leads to those changes, because many of the, in many cases, the changes can be reversible. Sometimes they progress, sometimes they don't. So the context turns out to be very important. Some of the groups, especially in Japan, that felt that the diagnosis of early chronic pancreatitis was 100% accurate was because the people making the diagnosis were not pancreatologists. They were radiologists that did the procedures, and they felt like what they saw was the gold standard and everyone should comply to that. So I think that the most important issue about early diagnosis is you're seeing abnormalities, but the interpretation is dependent on the context. You need to look at the trajectory, the risk factors, and the differential diagnosis. And by looking at that, you can make a determination with a high degree of accuracy as to whether or not the changes in this case are early chronic pancreatitis or not versus another case. And so it's more like more of a detection of an abnormality without being able to define what the process is without that context.
And I would agree with you in that sentiment or that enigma, that the need to clinically correlate versus just strictly relying on morphological appearance. I think that my hope is that studies like Proceed, that as many of us are in, will, and if we do serial type of imaging, we'll be able to better identify which features are predictive over time, and when and tell us then looking back which ones really mattered.
Right. So I have absolutely no criticism for your presentation, because your job was to review the recommendations, which you did in a very excellent way.
Thank you.
Yeah, I really enjoyed this session as well. And, as I was getting more interested in micronutrients in pancreatitis for various reasons, and now obviously solutes such as phosphate, I I wonder whether many of the other types of problems or risk factors leading to pancreatitis might be triggered by malnutrition or a reduced energetics type of situation. One of them is valproic acid. And, valproic acid rarely causes pancreatitis, but it's usually a severe pancreatitis when it happens. It usually happens, it's given in children who are usually neurologically impaired and often malnourished. And we've given valproic acid to mice up the wazoo and not had any evidence of pancreatic injury. But you wonder whether it's because you need to trigger the lack of ATP or bioenergetics or micronutrients of some type, which is why I think general commentary I was wondering about is whether in general we should be taking more strict dietary intake prospectively in many of these studies to look at the impact of micronutrients.
Very good point. I suspect that most gastroenterologists probably don't take a very detailed dietary history, but we know that alcoholics oftentimes substitute alcohol for dietary calories from other nutrients. So yeah, I think it's a very interesting observation about valproic acid.
We're running out of time. Just to maybe a couple of quick questions and points, if that's okay.
Okay.
Thank you.
I waited till now instead of from the other acute pancreatitis.
We will take your question.
I'm not a doctor, so you could relax on that point. However, 27 years of designing and doing studies in the chronic pancreatitis area, I think gives me an opportunity to say something, including the PROCEED study right now. We're still funding that to an extent. What I want to say is that, first of all, chronic pancreatitis, all of you have done a good job over all the years. I mean, all the technology and going up from a consistency of a statistician being able to define the case report forms so that we know what we were, at least know what we know. But where the problems with your group is to try to decide when there's enough damage to the pancreas that you could say it's chronic pancreatitis and not acute. Well, that's fine. That's your arguments. I'm not going to get involved in it. But what I'd like you to do is to share your expertise with the ones that are doing acute pancreatitis so they understand that it is important to have standard of care for acute pancreatitis defined so that insurance companies know what they pay. And people like me, when I want to support a study that you want to do, don't have to pay what the insurance company should have to pay. That's very important because, like, for example, in the acute pancreatitis state, is that we have to get informed consent for even the basic things that in the chronic pancreatitis area is accepted by everybody. And that makes it almost impossible to just collect zero data. In other words, data with placebo only. I have a study, I spent $170K and I got 5 patients with no drug. And I still don't have the data. And it's been 3 years. Well, 4 years. Started about the time when George was involved in the starting of his study. Same place. What we have to do is be smart. There is certain clinical findings or chemical findings, physiologic findings that we want to know about the pancreas. Let's find it out. We'll find it out in acute pancreatitis. We need your expertise to set a standard. I'll support the studies that would go forward with that particular position.
Yeah, that's a good point, Dr. Purich. So for acute pancreatitis, Melina had actually mentioned yesterday in our talk there is a prospective observational study in patients with acute pancreatitis that actually is going to be launched this month as part of the NIH consortium, which is the first longitudinal study of such kind other than what George just completed, the PAPE study. This is going to follow patients on a regular basis with dedicated evaluation. And in a subset of patient, morphologic assessment of the pancreas is going to be made on a regular basis to assess for changes that are occurring in the pancreas and how they associate with outcomes.
Well, you understand that it has impact with you, what they do in acute pancreatitis.
Correct.
For example,
Yeah.
that protocol that we were doing at 2 institutions, I won't mention them, had chemokines, interleukin profiles in it because they were trying to find out that information. Well, it'd be nice that if all the standard of care, since the standard care in acute pancreatitis is loose, so to speak, between institutions, to get an acceptance level, let's do a profile of some sort. We could change it each year once you know certain things statistically don't correlate, logistic regressions, whatever. But we're not learning anything. All we're doing is we're just jumping into here or there, spending lots of money on setting up a protocol for the background stuff. We should be doing that for, like you do in the chronic pancreatitis area. You're looking at a new EUS test, CT, MRI, what's going to be, some of it could be use of secretin, the drug that I have for collecting pancreatic fluid and do proteomics on it, who knows? But you don't have to, when you do all of that, start off with the protocol in the background of what is considered the standard safety data you want to know about the patient, which the insurance company should pay if you're normally doing that for the care of the patient. Okay?
Thank you, Dr. Pirch. We're
Thank
going
you.
to, in the interest of time, I'm terribly sorry, we're going to have to end questions now as we have another session coming on. I'd like to thank all our speakers today for your time, and we'll move on to the next session.
Yeah, thank you.
Welcome everyone to this last session, parallel session for the day. I'm Carlos Fernandez del Castillo from Mass General Hospital, and my colleague here is Dr. Gupta from the University of Miami, so local. And we are going to start with this session. We have 7 papers to review. We're going to stick on time, quite strict, otherwise we're going to finish late. The first paper is hematopoietic progenitor kinase 1 is a key regulator for RAS activity in early pancreatic carcinogenesis, to be presented by Dr. Hua Huang from the University of Texas MD Anderson Cancer Center. Yes, it'll be a video presentation.
Thank you for inviting us to present our work. Hematopoietic progenitor kinase 1 is a key regulator of RAS activity in early pancreatic carcinogenesis. Pancreatic duct adenocarcinoma is arising from well-characterized precursor lesions, including early stage as duct metaplasia, AEM, tiny lesions of different grades. The previous animal studies is clearly shown that mutant KRAS can drive the development of pancreatic adenocarcinoma. However, mutant KRAS have low RAS activity and is inefficient in driving this process. Mutant KRAS with additional genetic mutations or environmental factors or inflammatory pathways to maintain high RAS activity, which is required for the progression from pan-invasion to invasive carcinoma. Previous animal study also shows that proteasome activity is involved in the early stage of pancreatic tumorigenesis. Proteasome inhibitor can inhibit mutant KRAS-driven pan formation. My lab has been focusing on the functions of HPK1 signaling in pancreatic ductal adenocarcinoma. HPK1 also named MAC4K1, which is a mammalian SP20-like serine kinase of DCK subfamily. I want to quickly point out the new candidate mutant M46. M46 have a single amino acid replacement of lysine 46 to methionine, which abolish the ATP binding and the kinase activity of HPK1. Our labs have shown that HPK1 regulates several key signaling pathways, including ERK, P27, and P21, oncogenic X cell and XD signaling, leading to the decreased proliferation and decreased invasion of pancreatic carcinoma cells. So this is immunochemical staining of the HPK1 expression in human pan lesions and human Pdoc. And you can see here, HPK1 is highly expressed in the normal pancreatic ductus, but it is decreased in pan-1 lesions and is completely lost in pan-2 and pan-3 lesions and pancreatic ductal adenocarcinoma. The HPK1 is completely lost in more than 90% of pancreatic ductal adenocarcinoma samples. So the loss of HPK1 expression in pancreatic ductal adenocarcinoma is mediated by E3 ligase FBXW8 proteasome pathway leading to the HPK1 protein degradation. So the major objective of this study is to examine the functions of HPK1 in early pancreatic tumorigenesis and in regulation of RAS and RAS signaling. So we first examined the expression of HPK1 in ADM. So we treated the wild-type mice with stoning for 2 days, and the mouse pancreatitis were harvested at day 3, day 4, and day 14. As you are shown here, at day 3 and day 4, the mouse pancreas have severe acute pancreatitis and extensive ADM. At day 14, the mouse pancreas is almost fully recovered. We detect markedly increased HPK1 expression in the pancreas at day 3 and day 4, and which is returned to normal at day 14. We also observed an increased ERK activation at day 3 and day 4, which is consistent with that RAS activity is involved in ADM. We confirmed this result with immunochemistry, which showed the HPK1 and also expressed in the ADM, but not in the normal pancreas. So then we generated the transgenic mice to pack the HPK1 or candidate mutant M46 into the pancreatic epithelial cells using pancreatic epithelial cell specific the bacteria. And this is showing you the HPK1 and M46 in the pancreatic epithelial cells, but not in the ductal cells or other cells in our transgenic mice. We then performed the RNA-seq analysis using the mouse pancreas after being treated with the insulin for 24 hours to activate HPK1 activity. We observed a distinct gene expression profiling in HPK1 bacteria mice compared with M46 or bacteria mice. We observed more than 600 genes upregulating and more than 400 genes downregulating. Using the gene set enrichment analysis, we discovered that HPK1 suppresses the KRAS signaling up and activates the KRAS signaling down pathways. This suggests that HPK1 plays an important role in regulating RAS and RAS signaling. We then examined the RAS activity and ERK activity in our transgenic mouse model. We treated our mouse with stoling, and the mouse pancreas was harvested at 1 hour and 2 hours after treatment. As shown here, that HPK1 can inhibit both basal and induced RAS activity at 2 hours, and compared with wild type control mice. Similarly, we observed that HPK1 can inhibit the basal and induced ERK activation at 1 and 2 hours compared to wild type control mice. So this is immunochemical thing of both work, which confirms that the activation of ERK is reduced in HPK1 transgenic mouse pancreas. We then performed a 3-week experiment. We treated our transgenic mice with stoling for 2 weeks, and the mouse was sacrificed at the end of week 3. We observed that M46 increased the RAS activity, HPK1 decreased RAS activity compared with the wild type control mice. It is very interesting that we observed that M46 back mice, more than 64% of them develop pain lesions, which are confirmed by CK19 and option below here. Now the wild type mice or HPK1 back mice develop mouse pain lesions. We then crossed our M46 mice with KRAS back-free mice. So what we found is that M46 promotes the development of chronic pancreatitis and the pain lesions and their progression to high-grade pain 2 and pain 3 lesions. And we did not observe high-grade pains in our KRAS back-free mice. So I want to use this cartoon to summarize my talk. We believe that HPK1 is a novel tumor suppressor and a novel regulator of RAS activity. During the early pancreatic tumorigenesis, the increased proteasome activity or overexpression of FBXW8 leads to the HPK1 degradation. Or if we overexpress M46 candidate mutant M46, we can lead to the marked increase of KRAS activity, and which driven the pancreatic pain progression to invasive carcinoma. So therefore, we identify HPK1 novel function as a RAS regulator. This is my acknowledgement. I will stop here, and I would be happy to answer any of your questions. Thank you.
Thank you, Dr. Wang. Any questions from the audience? Could you tell us if there are any other human tumors where HPK1 could be also overexpressed in early lesions or precursor lesions?
Sorry, can you hear me?
Yes, we can hear you.
Yeah, they're studied in the breast cancers, which shows that in the ER positive tumors, the patient have better survival. But we don't have many otherly.
Okay, I think our connection is poor. Well, thank you very much. And we are going to move to the next presentation. Thank you.
We move on to next presenter, who is Sandeep Swain from Duke University School of Medicine. And title of his presentation is PCO1 channel opening induces stellate cell activation and pressure induced pancreatic fibrosis. Thank you.
Okay. Thank you, APA, for this opportunity. So already everybody described about what is the chronic pancreatitis and fibrosis. The chronic pancreatitis is a progressive inflammatory disease, generally that is characterized by fibrosis. and loss of exocrine and endocrine insufficiency. In chronic pancreatitis, if you see, it can be reduce the quality of life in patient due to the inflammation caused abdominal pain and malabsorptions due to loss of exocrine cells and endocrine cells loss cause diabetes mellitus. There are several common causes of chronic pancreatitis. Everybody described like heavy alcohol intake and obstruction and genetic, and some are autoimmune disorder and some of unknown region. If you see in healthy pancreas, pancreatic stellate cells are quiescent in nature. Generally, they have spherical and contains perinuclear vitamin A containing fat droplets. Upon activation, the pancreatic stellate cell increase the extracellular matrix protein and loses his perinuclear fat droplets. So in pancreatic fibrosis, this is the main critical process during pancreatic fibrosis. And if you see here, apart from quality of life in patient decreases, chronic pancreatitis also increases the risk of cancer. And during pancreatic ductal adenocarcinoma, the high desmoplasia surrounding the tumor is mainly consists of extracellular matrix protein like fibrogen and collagen, fibronectin and collagen that can inhibit the drug treatment. And if you see, there are several common factors can cause chronic pancreatitis and fibrosis, and already described my previously my mentor, Dr. Roger Liddell, that a duct tincture narrowing the duct, which can dilate the distal part of the pancreas, and development of a cyst and pseudocyst can cause the pancreatitis and fibrosis, and a tumor during abdominal tumor may cause pancreatic fibrosis, and duct stone and calcifications and protein depletion also can cause chronic pancreatitis and fibrosis. So if you see all the factors can increase the pancreatic duct pressure or elevate the pancreatic pressure. So the main cause of pancreatic fibrosis is the activated stellate cell, but we don't know how pressure cause activation of stellate cells. So recently we discovered that pancreas senses pressure through the mechanically activated ion channel PGO1, and this is the quite big protein present at the cell membrane, and the three braid-like structure of the PGO1 which sense the pressure and open the channel. There are several mechanical force can activate PGO1 such as static pressure, shear force, and if you stretch the membrane, and it immediately carry the calcium from outside to inside the cell. And chemically, you can activate PGO1 by UDA1 and like a tarantula toxin GSMTS4, which can block the PGO1 channel. So we detected that high amount of PGO1 is expressed in mouse pancreatic stellate cells. This is the immunostaining images showing the mouse pancreatic stellate cell express GFP, glial fibrillary acidic protein, a possible marker for stellate cell. We don't have not a specific marker for stellate cell. Then all cells have a PGO1 protein. And we observed that all cells express sensitive to UDA1, the PGO1 agonist, and UDA1 dose-dependently elevate intercellular calcium concentration in pancreatic stellate cells. Then we knock out the PGO1 in pancreatic stellate cells, and we observed that pancreatic stellate cell knockout pancreatic stellate cell did not respond to UDA1, and the long sustained calcium rise caused by UDA1 is completely blocked in knockout mice. Like mouse pancreatic stellate cell, we observed the high amount of PGO1 in the human pancreatic stellate cell, and exactly we did that all human stellate cell also responded to UDA1. High concentration of UDA1, 25 micromolar, caused sustained calcium rise that was blocked by GSMTS4. So we can demonstrate that the PGO1 effect is the UDA1 effect is PGO1 specific. Then we try to check the effect of PGO1 in pancreatic stellate cell activation. What we did, we isolate the human and mouse pancreatic stellate cell and culture in the matricial coated plate. We culture matricial coated plate to maintain the stellate cell in quiescent. We less serum and matricial coated plate. As you see here, that all the in control stellate cells, all the cells have a perinuclear fat droplet, the green droplet and rounded shape. When we applied UDA1 25 micromolar, within 24 hour application of UDA1 cause 80% of pancreatic stellate cell lose their fat droplets. Then after 4 days of UDA1 treatment, we observed that all pancreatic stellate cell increase the synthesis of extracellular matrix protein, fibronectin, and collagen. And likewise, after 24 hours of one treatment, we observe that there are increasing MRL level of fibronectin, TGF beta, and collagen along with PGO1 channel. Then we try to study the effect of mechanical force on pancreatic stellate cell. So we used here a shear stress approach. Here we culture the stellate cell in the chamber. Then the shear stress was generated by flowing the liquid through the chamber. So here we can control the flow rate so that we can control the amount of shear stress. We can control the time of application and strength of the shear stress. So initially when you applied low shear stress for longer time, like 1 minute, we produce that only produces transient calcium rise in pancreatic stellate cell. When you applied high shear stress for 5 seconds, only for short time, that also produces a transient calcium rise. When you applied high shear stress for longer period of time, 1 minute or more than that, that produces a long sustained calcium rise. And that sustained calcium rise is blocked by GSMTS4 PGO1 blocker. So it is demonstrated that mechanical force mediated long sustained calcium rise is PGO1 dependent. Then you try to examine that if PGO1 can activate pancreatic stellate cell. So we use high shear stress for 10 minutes. And within 24 hours, we observed that there is significant decreasing pancreatic perinuclear depth plates when treated with high shear stress for 10 minutes. Then we applied high shear stress for twice and interval for 24 hours. Then after 3 days, we check the expression of fibronectin, and all the human stellate cells then increase the more fibronectin than to control. Then we try to examine if PGO1 can induce pressure-induced pancreatic fibrosis. So we used a clinical relevant model by ligating the pancreatic tail region of the pancreas. As you see here, we ligated the tail region of pancreas, and after 8 days after ligation, the tail region of pancreas is quite fibrous and white, and the head region was unaffected. And we measure the pressure after 5 minutes after ligations. After 5 minutes after ligation, we observed that the pressure at the tail region of pancreas increases from 8 mm mercury to 23 mm mercury. Then after 38 days after ligation, we observed that there is substantial and increasing fibrosis in the tail region of wild type mice, not in the PGO1 KO mice. And that is, you can see here the increasing mesenchymal staining, which represent the collagen deposition. And head region of the pancreas, both in wild type and KO mice, was unaffected. So in summary, I can tell that high pressure or mechanical force activate PGO1 that lead to sustained intercellular calcium elevation in pancreatic stellate cell, cause stellate cell activation, and increases the extracellular matrix protein deposition, induces fibrosis. So I'd like to thankful and acknowledge to my team member, my mentor, Dr. Rajal Lidil, and my colleague, Dr. Joel Romak and Dr. Steve Vigna. Thank you, and Grant. So hopefully we have a small team, but good team. Thank you.
Thank you. Very excellent talk. Now floor is open for questions. Any questions?
Wonderful work. Maria Bacaro from Buenos Aires. Do you know if PSO1 is in the cilia of the plasma membrane? Or in what compartmentalization of plasma membrane could be those channels? Probably the cilia is the place where detect share. That's why I asked you if you know that localization or not.
Actually, I gone through the paper, the PGO1 expressed in the plasma membrane of the all cells. And then no study found till now they are expressed internalized or cytoplasmic or any organelle, internal organelles. No first study found. Maybe cilia, I couldn't tell, but more it's present in the plasma membrane.
And in the plasmic reticulum also?
No study found till now. Yeah.
Okay, yeah. Thank you very much.
Yeah.
Very nice work. I had a similar type of question. I've followed your work with acute pancreatitis and now with this chronic pancreatitis. In the acute pancreatitis published work that you showed that acinar cells express PSO1, and you speculated that that was the reason or that there was pressure on the acinar cells during acute pancreatitis. And now I think it sounds like with the stellate cells, there's a similar pressure. I guess that's a similar question. How does pressure somehow get to the stellate cell when there's ductal pressure?
Yeah, so I think for that, I can tell that generally pressure develop, we can tell that generally there is no the partial dot, the like partial dot experiment would do it, that's like sustained pressure conditions. The sustained pressure condition generally occurs like after acute pancreatitis or after chronic pancreatitis, like drug tincture, irregulatory drug, that lead to the pressure development in the pancreas. But to answer your question, I have the slide. Can you go? Sorry, I didn't. I have one slide I included here. Even if you knock out Pjo and pancreatic acinar cells, we couldn't protect the pancreatic fibrosis. Pancreatic fibrosis is protected in knockout Pjo and knockout in stellate cells. So as you see here, end of the section slide. So yeah, sorry. So here, so we did partial dot ligation in pancreatic Pjo knockout pancreatic acinar cells and Pjo knockout stellate cells. Maybe Pjo knockout in responsible acute pancreatitis, but sustained pressure is more, the Pjo in stellate is more important. And if you see here, Pjo knockout acinar cell didn't protect the pancreatic fibrosis. So I couldn't tell the exact how the pressure in chronic stage, what are the conditions, because most of the describe that is quite complicated, but I can tell that Pjo in stellate cell is more important in pancreatic fibrosis rather than Pjo in acinar cells.
Thank you.
Yeah, thank you.
I have a question too. You use the pressure-induced pancreatic fibrosis models kind of thing. Is there in other models where there is no pressure, like alcohol-induced pancreatitis, does you see the similar kind of effect?
We didn't study alcohol pancreatitis, but the possibility that once alcohol pancreatitis develop, that the tissue edema is there. So it's probably the edema also cause pressure develop there. So maybe chance of the Pjo role maybe play there, but we didn't study, but possibly. Most of the pancreatitis, they have edema and the pressure.
Thank you.
Yeah.
We want to next.
Yeah, thank you. Thank you.
Our next paper will be presented by Dr. Nikki Lytle, and it's entitled Liver Damage Enhances Pancreatic Cancer Liver Metastasis. She is from the Salk Institute for Biological Studies.
Okay, thank you so much. And I just have to say that my paper is not quite ready for submission, but I'll do what I can here. I probably don't have to tell this crowd that pancreatic cancer patients have a very high rate of metastasis. But if you start digging into the data, it becomes clear that certain populations are much more metastatic than other populations. So what I'm showing here is rates of metastasis and subsequent poor prognosis in those patients that, for example, have high alcohol consumption, are obese, or have high cholesterol. And in all those situations, there's been some biology trying to understand what drives metastasis, but there's still a lot of information that's lacking there. And what this really suggested to me, or at least proposed, was that could liver damage itself promote the survival and outgrowth of disseminated pancreatic cancer cells? One form of liver damage that you may not be as familiar with is known as chemotherapy-associated steatohepatitis, or CASH. Patients are really bombarded with a concoction of a lot of different chemotherapies and often go through multiple rounds of chemotherapy. And we know that many of those chemotherapies can actually drive liver damage. Steatohepatitis is one of those forms of liver damage, but we also see sinusoidal obstruction shown on the left and steatosis shown on the right. Sometimes pathologists will observe hepatocyte ballooning, sinusoidal dilation, a number of different histopathological issues. So I wanted to test if this chemotherapy-associated liver damage may actually drive metastasis. And I did this by first treating non-tumor-bearing mice with either chemotherapy or vehicle. And this was done 2 rounds, 4 weeks each, essentially trying to model what the chemotherapy regimens that patients might be seeing in the clinic. After their final dose of chemotherapy, I waited 5 days and then transplanted in tumor organoids via the portal vein as a metastasis model to the liver. These pancreatic tumor organoids were treated with the appropriate chemotherapy that's being tested in the setting. And they were partially digested into organoid clusters to model the circulating tumor clusters that are observed in patients. I then tracked these mice for overall survival. And I'm in the process of testing a number of different chemotherapies, but what I'm going to tell you about today is results from gemcitabine and oxaliplatin. I do want to note that both regimens had very high toxicities in these mice, but really do overlap what's observed in patients as well. So you have a reduced weight loss or reduced weight gain in this case. They also show, this is peripheral blood samples, signs of immunosuppression, anemia, and thrombocytopenia. But here's the overall survival data. On the right is the graph comparing mice that received vehicle or gemcitabine, and there's absolutely no difference in overall survival. In contrast, on the left are mice that received either vehicle or oxaliplatin. And there's a profound increase in metastatic burden and a reduction in overall survival. And this has been repeated and is significant. Knowing that chemotherapy leads to immunosuppression, our first kind of stab at this is that it's really inhibiting the immune compartment to clear disseminated tumor cells that are landing in the liver. So I collaborated with Dr. Sue Keck's lab at the Salk Institute, who helped us do immune profiling within the liver of mice treated with either vehicle or oxaliplatin or gemcitabine. And to our surprise, oxaliplatin, shown in blue, really had no difference in most immune populations. And in fact, we saw that there was an increase in the CD8 T cell population, which doesn't fit the survival data. And of note, we also looked at monocytes and macrophages and a number of different, nothing was really changed. So this told us that maybe this is not what's going on. So many people in this room may know that the liver is actually incredibly regenerative. You can injure it over and over again, and it will continue to heal itself. And a lot of the biology has been worked out there. What I'm showing you here is a summary of some of this biology. And on the left is a number of growth factors that are induced in order to help livers regenerate. And for those who work with pancreatic tumor organoids and stuff, those same growth factors we actually use to feed our organoids. So this really told me that it's possible that during the liver regeneration process, those factors are feeding disseminated tumor cells. So to ask if this is maybe what's happening in our setting, I took the approach of isolating liver interstitial fluid, or LIF, and then sent that liver interstitial fluid for screening of inflammatory signaling that may actually be communicating with the tumor cells. So this is protein levels of liquid that is being secreted in the liver itself. This is the biggest hit that I'm showing here. This is oxaliplatin, liver interstitial fluid from oxaliplatin treated mice versus vehicle. And reproducibly, this protein called TIMP1 kept coming up as the biggest hit in the interstitial fluid. Of note, there's also IL-11 that's highly upregulated, MIP3B, which is CCL19. And then we also have IL-6 and interferon gamma, which is not surprising because those are damage signals that have been shown to be upregulated in the liver. But TIMP1 and IL-11 are actually quite interesting, which I'll get to on the next slide. But I do want to note that in the gemcitabine, in the liver interstitial fluid from gemcitabine treated mice, TIMP1 and IL-11 are not upregulated. So this is specific to the damage that drives metastasis. So work by Stuart Cook in Singapore and a number of other labs have actually shown that this IL-11 TIMP1 axis may be driving NASH, which is non-alcoholic steatohepatitis, and overlaps quite closely with CASH, or the chemotherapy-associated steatohepatitis. So in this regard, activated hepatic stellate cells or even damaged ballooning hepatocytes will secrete IL-11. The IL-11 will go on to bind the IL-11 receptor that's expressed both on the hepatic stellate cells and the hepatocytes. And in response to that, both the stellate cells and the hepatocytes can then go on and secrete high levels of TIMP1. And TIMP1 has had recently a number of papers come out from numerous groups showing that in pancreatic cancer, it's associated with worse prognosis. Its expression is linked to high levels of jaundice and cachexia in patients. And finally, there was a functional study showing that TIMP1 itself may be driving metastasis to the liver, possibly through activation of neutrophils. So finally, sorry, this is my last slide. I do want to note that if we let these mice recover for 6 weeks after treatment, so now this is giving the time for the liver to heal itself, those levels of IL-11 and TIMP1 come back down, and I completely lose my pro-metastatic phenotype in the liver. So this is truly just an acute phase while patients are receiving chemotherapy. So moving forward, I'm working on trying to understand who is in our setting, who is expressing TIMP1 and IL-11. I'm doing single cell RNA-seq to answer that question. I'm actually working with Stuart Cook in Singapore, who's going to be providing some IL-11 antagonists for me to functionally test if I can block this pro-metastatic phenotype. And then finally, mechanistically, how is TIMP1 doing this? So I want to thank my advisor, Dr. Jeffrey Wall. He's been fantastic in really kind of going through the highs and lows of this project. I work closely with Dr. Natalie Lutala and Dr. Kathleen Del Giorno, who are both here. So yeah, we can certainly talk about some of the projects we have together. And finally, thank you to the APA for giving me this opportunity. So.
Thank you, Dr. Little. This paper is open for discussion. Before we start the first question, did you show that your livers actually develop CASH?
That's the next slide. I do not have advanced CASH in my livers, but what I do, I'm showing right now as a comparison NAFLD liver from diet-induced. But what I do have is hepatocyte ballooning and sinusoidal dilation. The ALT and AST levels are actually quite bizarre here, where oxaliplatin drives up AST but not ALT, and so I'm working with a number of people at Salk and beyond trying to understand what's going on with these.
So my point, this could be a different kind of damage from oxaliplatin to the liver.
Yeah, so I'm definitely hesitant to call this CASH. I'm more calling it chemotherapy-associated liver damage. Yeah, yeah.
Hi, nice talk. I was wondering, so did you, I might have missed this, but when you detected TIM1, that was from blood? You saw that was
No, that was the liver interstitial fluid.
liver interstitial fluid.
Yeah, so you can isolate the fluid that's essentially sitting in the liver between cells.
Okay, so you're pretty confident that, because you know, we do know that TIM1 is also like produced by the pancreatic tumor itself. So I was wondering if you, like, how are you able to distinguish where it's coming from? I saw that that's some of your future direction as well.
Yeah, that I am doing like RNA-seq to understand which populations within the liver, but this fluid was directly from the liver. I will say TIMP1 is up in circulation in pancreatic cancer patients as well. So it seems to be a driver in many regards. Yeah.
Yes, you know, TIM1 is a inhibitor of matrix metalloproteases.
It is, yeah.
Which is the common wisdom of thought is matrix metalloprotease drives metastasis. Here you have an inhibitor going up correlates with metastasis. How do you reconcile this?
Actually, the matrix metalloprotease literature is split. It's not across the board, and TIMP1 is a negative regulator of 13 different matrix metalloproteases. So it could be working on one over another. Also, it's been shown to actually interact with integrin beta-1 and activate that pathway as well. So and integrin beta-1 has been a pro-tumorigenic signaling pathway. And finally, like I said, in the pancreatic cancer literature showing that TIMP1 was pro-metastatic in the liver, it was activating neutrophils and helping the tumor cells crawl through the liver via neutrophil activation.
Indirectly. Okay, thank you.
One brief question.
Hi, this is Sid from University of Miami. Actually, I wanted to ask the same question, but so you didn't see any changes in the immune cell, so suggesting that could be a tumor cell driven phenomena. But since you're focusing on the growth soluble mediators, how can you, like, just moving forward, how will you trying to correlate the changes in the soluble mediators with regard to there's no change with the immune cell composition? So it could be something driven by, I guess, some of the tumor cell intrinsic signaling pathway that could be driving this.
Yeah.
With regard to the metastasis,
Definitely. And so that's why we're testing it in TIMP1 knockout mice, which we're in the process of getting right now, and this IL-11 inhibitor, which actually, to your point, does impact the immune compartment as well. I will say that we are redoing this immune, just because we want to be confident about it. We are redoing the immune testing. Like, it's possible that the populations were not changed grossly, but that they're not able to respond to disseminated tumor cells when they initially see that signal. So we're going to isolate immune from oxaliplatin vehicle treated mice and then expose them to the pancreatic tumor organoids and see if their activation status changes.
Have you looked at any of the signaling, like your STAT3 or MEK or ALK in those different models that you're using, just to see whether that is sort of driving this phenomenon? Just not looking at the immune angle, I'm saying.
Within the tumor cells?
Yeah, within the tumor cells.
Well, the tumor cells that are being transplanted are completely equivalent between the, right?
Okay.
They're going in via the portal vein from the exact same treatment groups.
Okay.
So the tumor cells are controlled for.
Okay.
Yeah.
Thank you.
Yeah.
Our next presenter is Dr. Taisuke Baba. He's from Massachusetts General Hospital, and title of his presentation is "A Comparison Between PDX Tumors and PDX-Derived Cell Lines Highlights the Molecular Plasticity of Pancreatic Ductal Adenocarcinoma."
Okay, hi, I'm Taisuke Baba from Mass General Hospital. Today, I would like to talk about the cell plasticity of Pdoc, or rather, how flexible they are to change the Pdoc subtype program. So various molecular subtypes of Pdoc have been proposed, including our own. And they have some differences, but still they come to a similar conclusion. There are two major subtypes, basal-like and classical. Basal-like subtype tumors are characterized by aggressive biology and poor patient survival. And classical tumors are characterized by high sensitivity to chemotherapy and better patient survival. According to the past reports, about a quarter of patients are classified as basal-like subtype. However, when Moffitt reported their own classification, they also found the Pdoc cell lines they tested were all classified as basal-like. And they said cell line models represent only one subset of Pdoc. However, what causes this gap is unknown. There are two possible theories about this. One is selection. So only highly proliferative and aggressive tumors can grow under 2D condition. Or cell plasticity. So some of them actually used to be classical tumors, but they changed the subtypes and become basal-like cell line. To understand the mechanism, we compared our PDX tumors and cell lines. Since 1995, we have been collecting pancreatic tissues in our biobank. And from these tissues, we have established PDX tumors and also created cell lines from these PDX tumors. So in this study, we compared 24 matched pairs of our PDX tumors and cell lines. This is a plot of classical scores and basal-like scores. Scores are calculated based on Moffitt and Bailey's genes. Every single dot represent our PDX tumors. And those with high classical scores, they are classical tumors. And those with low classical score and high basal-like score, they are basal-like tumors. The proportion of classical versus basal-like tumors are very similar to the proportion that Moffitt reported, which means our PDX tumors recapitulate the clinical heterogeneity of Pdoc subtypes. So these dots spread out widely in this map. However, when it comes to cell line, these classical tumors have gone, and then heterogeneity was lost, and now most of our cell lines are basal-like. This is a paired comparison of classical and basal-like scores. Again, PDX tumors have a wide range of scores and maintain heterogeneity. But when it comes to cell line, these scores converge to a point, especially the classical scores went far down from PDX tumors and pushing cell lines to a basal-like status. This is a volcano plot comparing PDX tumors and cell lines. Morphous classical genes are shown in blue, and basal-like genes are shown in orange. As I showed in the last slide, classical genes are significantly upregulated in PDX tumors. However, GATA6 did not change. GATA6 is a key transcription factor in classical subtype. So the GATA6 is reported to drive the classical program. But nevertheless, GATA6 did not significantly change here, which means this subtype shift was caused independently of GATA6 expression or in the downstream of GATA6 pathways. For example, HNF1A and 4A functions in the downstream of GATA6 pathways and preventing cells from becoming basal-like subtype. So these factors may be contributing to this strong suppression of classical program. So our results suggest that Pdoc cell plasticity is playing a key role in classical to basal-like shift in cell line. However, single cell analysis revealed that some tumors have heterogeneity of Pdoc subtypes in a single tumor. For example, this is from one patient's tumor, and most of these single cells is expressing classical signatures. But the tiny population on the left are harboring basal-like signatures. And what if these classical cells die on the 2D condition and basal-like cells survive on there? Then it might be possible that basal-like cells become predominant here, and this cell line will be classified as basal-like subtype. So to further confirm the plasticity of Pdoc, we implanted our cell line to mice and tested the subtype scores. So we implanted 3 different cell lines from classical tumors and 3 different cells from basal-like tumors. And surprisingly, the classical scores were restored in the implanted tumors, but it happens only in classical tumors and not in basal-like tumors. And furthermore, we see these tumors back to dishes, and then the classical scores were downregulated. So the classical score can go up and down in response to their growing environment. In conclusion, the predominance of basal-like cell line is at least partially due to the remarkable plasticity of the classical gene program in Pdoc cells. And classical to basal-like shift is induced independently of GATA6 expression. And we definitely need a better research model to recapitulate the clinical heterogeneity. I would like to appreciate my lab team, and especially Andrew Luis. He gave me a big support on my project. Thank you very much.
Great talk. The floor is open for question, and I'll start with one question. So field is now moving more towards like using organoids. Did you ever look in organoids, PDX drive organoids? How does they behave in context to classical versus basal?
Yeah, thank you for asking. Actually, we haven't tried by our own, but I analyzed the published data set and they're comparing. So I compared the cell line versus organoid or spheroid or PDX tumors and primary tumors. And consistent with our result, primary tumors or PDX tumors, they are much high classical signatures. But when it comes to spheroid, there is a little bit more classical. But the data set uses like organoid co-culture with stellate cells and macrophages in matrigel, but this condition did not change anything, like literally anything in context of classical signature. So now I don't have an answer, like, but maybe we need some optimization, or maybe organoid is not a good model. I don't know. Sorry.
Interesting. Also, like within cell line, in the context of cell lines, did you ever compare? I think there's a lot of study done, which is talking about the old passage, the young passage of cell line. And in your context, how like passage they were, like how frequently passage, and then you look for, does that affect them?
Yeah. So I implanted the cell lines to mice. That is passage around 30 to 50, maybe median passage was around 40, but still they have very good plasticity. They went back to classical. And after tumor, between tumor to cell line, the last part is about a week, like just get rid of stroma cells and send RNA sequencing, and the classical score went down. So very quickly they changed the classical score. So they have plasticity.
Let's see. Hi, good talk. Quick question. Well, so one thing I wanted to kind of get a little clarification on. There are a lot of studies coming out now with pancreatic cancer organoids and PDXs that really show that there's an enrichment for the classical subtype in culture, even after a couple passages, like from like early harvesting. So we see this in the cell lines, we see this in the PDOs, but then also conversely, in our lab with some of the data that we're showing, because we run these classifiers all the time, we find that sometimes with pancreatic cancer cell lines like Miopaca, for example, it'll get called as being more basal-like, but then when we investigate on a per gene basis across single cells why that's the case, we find that it's only called basal based on the expression of KRT15 and AREG. So my question for you then is, as you're looking between these classifying, these calls for, okay, how is it transitioning between classical or basal or back again? Are you digging down onto the per gene level to see if there's one or two genes that are really driving that call in individual samples? Or is it more of a bulk thing where the caller says it's that, so you're going with the call? Does that question make sense? I'm hoping that question makes sense.
I mean, the classification I showed is based on the consensus clustering about using the RNA sequencing data.
Okay.
And the scores I showed there was Z-score, so average expression of basal-like genes, not specific genes.
Okay, so that's what I'm wondering, because we did a very similar thing, and when you look at the overall average score, it will present as basal, it will present as classical. And to me, given what I'd known about the polyclonality of those lines, I'm like, that doesn't add up. There should be more heterogeneity there. So then on a per gene basis, we see that it's only basal because it has expression of two genes on the list and no expression of genes on the classical list. So it's a little bit nuanced, and sometimes the classifiers aren't super sensitive to that. So I was just wondering how that was looking, but if you haven't looked into it, maybe something to dig into.
Thank you.
Yeah.
Great discussion. Thanks.
Our next talk is a video presentation from Italy, from Dr. Stefano Francesco Crino from the University of Verona. and the title of his presentation is Impact of Biliary Stents on the Diagnostic Accuracy of EUS-Guided Tissue Acquisition of Solid Pancreatic Head Lesions, a multi-center study.
Good evening, and thank you for the possibility to present the results of our study entitled Impact of Biliary Stents on the Diagnostic Accuracy of US-Guided Needle Biopsy of Solid Pancreatic Head Lesions, a multicenter study. In patients with pancreatic head mass with jaundice, biliary decompression is perceived as a more urgent procedure than obtaining cytohistological diagnosis. And despite US and ERCP are feasible in a single endoscopic session, in a real-life world, biliary stenting sometimes precedes USFNB. If an indwelling biliary stent negatively impact on the diagnostic yield of USFNB for the diagnosis of pancreatic lesion is still unknown. Indeed, to date, only 6 retrospective studies investigating this topic have been published with conflicting results. Moreover, most of these studies included patients who underwent USFNA and not USFNB. Therefore, we performed a retrospective multicenter study involving 5 Italian centers, including all consecutive jaundiced patients with solid pancreatic head lesion who underwent USFNB between January 2017 and December 2019. Pathological interpretations were classified according to the Papanicolaou classification, and the gold standard to assess the final diagnosis was surgical pathology whenever available, or in non-resected patients, clinical and radiological follow-up of at least 12 months. To calculate the diagnostic performance of USFNB, we used both strict and non-strict criteria. In particular, when strict criteria were used, interpretations of suspicious for malignancies were counted as negative. Differently, in non-strict criteria, suspicious for malignancy were considered as positive. Analysis was performed using logistic regression, and subgroup analysis, including patients with an indwelling biliary stent, was also performed. In this table, you can find the baseline characteristics of the patients included. We included overall 842 cases, 495 without stent, and 347 with stent, in particular 217 with plastic and 130 with metal stent. Lesion size was similar between the 2 groups, and there was a slightly higher number of cases sampled with end-cutting needles in the group with stent. The most common needle was the 22 gauge, and the mean number of passes was around 3 in both groups. The majority of cases were sampled without the use of rapid on-site evaluation, and pancreatic cancer was the most common diagnosis in the 2 groups. Here I'm showing the results using strict criteria. And as you can see, sensitivity and accuracy in the group without biliary stent was around 92%, which was significantly higher than that obtained when a biliary stent was already placed, which was around 86%. And in multivariate analysis, we identified 3 factors independently associated with diagnostic accuracy. Lesion size, in particular, larger lesions were easier to be sampled and associated with better accuracy. Those lesions sampled with a larger bore needle demonstrated higher accuracy. Differently, the biliary stent, the presence of biliary stent, was negatively associated with diagnostic accuracy. In the subgroup analysis of patients with biliary stent, we identified the needle caliber as the only factor associated with better diagnostic accuracy. Interestingly, the type of biliary stent, metallic or plastic, did not impact diagnostic yield. Results were similar when non-strict criteria were used, with higher sensitivity and accuracy in the group of patients without biliary stent compared with that in the group of patients with biliary stent. And in the multivariate analysis, again, lesion size was significantly associated with a better diagnostic accuracy, and the biliary stent negatively impacted on diagnostic yield of USFMB. Therefore, in conclusion, biliary stents negatively impacted diagnostic accuracy of USFMB for the diagnosis of pancreatic head lesions. And in jaundice patients, preferably, USFMB should precede ERCP, especially in the case of small tumors. Moreover, when a biliary stent has already been placed, the use of large bore FNB needles could optimize the diagnostic yield. Thank you very much for your attention.
Thank you, Dr. Crino, and congratulations for putting such a large database together. I think it's
Thank you.
remarkable and potentially very useful advice for endoscopists and clinicians who struggle with getting a negative biopsy, right? Which is something that can hamper patient care and progression. Are there any questions for Dr. Crino? So I was surprised that there was no difference between the plastic and the metal stent. Do you have any thoughts? Did you expect that there would be a difference?
Yeah, we were surprised too, in particular because in a recent study from England, there was a significantly difference between the two stents, the two types of stents. I think that probably in our study, the plastic stent was similarly associated with a negative accuracy compared to metallic stent, because anyway, when you perform an ERCP, you produce some inflammatory change in the pancreatic tissue around the biliary duct. So we could speculate that this inflammatory change can negatively impact on accuracy. This is the reason that we give to this finding.
One last question, and maybe it was in your tables, but not clear. What was the median duration between the ERCP and the endoscopic ultrasound in those patients who had it preceding?
We analyzed also the median time between the two procedures in the subgroup of patients with an indwelling biliary stent. The median time was exactly, I give you the exact number of days, is one day median, but there was no association with accuracy.
Interesting. Well, there's no other questions, so thank you for staying late for doing this.
Yes, thank you. Thank you very much. Goodbye.
Now we move on to next presenter, who is Dr. Li Chang from Johns Hopkins University. Title of the presentation is Rationale of Using the Combination of Anti-PD-1 Antibody and Anti-IL-8 Antibody for the Pancreatic Cancer Treatment. Thank you.
Yeah, thanks for the program committee for select our abstract for presentation. And here I represent the first author, Dr. Pan Li and Dr. Noah Rogig, and who cannot be here. And so I'll, on their behalf to present their works. So yesterday you may have heard from Dr. Ossipo, actually is in my group. We together actually developed these new adjuvant platform trials and to provide the tumor biospecimens to study the effect of the vaccine in combination with the nivolumab anti-PD-1 antibody in the resected patient following the window opportunity new adjuvant treatment of the vaccine and the nivolumab. And in this study, by using the multiplex immunohistochemistry and also using the RNA sequencing, and as he already described yesterday in his talk, we find that in the pre-treatment biopsy, the tumor-associated neutrophil is associated with poor prognosis in the patient group that receive vaccine and nivolumab. And consistently, we also see the increase of the expression of the receptor of IL-8, particularly the CXCR2 on the myeloid cells is increased in the patient who actually received the GVAX vaccine and the nivolumab. And you may also aware of a recent two publication in the Nature Medicine show that higher plasma level IL-8 correlate with the poor prognosis following the treatment of anti-PD-1 antibody in multiple cancer disease types. And here is a showed example with the urothelial carcinoma. We also measured the plasma IL-8 level in our patients in these neoadjuvant platform trials following the vaccine and or vaccine plus nivolumab. And we find a higher plasma IL-8 levels correlate with the poor survival only in the arms that patient received the treatment of vaccine and plus nivolumab, which is consistent with the two published paper in the Nature Medicine. So we know myeloid cells are recruited by the IL-8 into the tumor microenvironment. In general, we think the myeloid cells are predominant immunosuppressive cell in the tumor microenvironment. So based on our data, we're thinking we should target IL-8 in pancreatic cancer. However, there is no mouse homolog of IL-8. That means we wouldn't be using the syngeneic model to test these drugs in the preclinical setting. So what we do actually is we use the humanized model. In my laboratory, we reconstituted the NG mice with the ex vivo activated human T cells and also infused the mice with a combination of CD16 positive B solid myeloid cell and also CD14 positive myeloid cells. And these mice will be implanted orthotopically with tumor cell lines that is with the luciferase, so we can monitor the tumor growth with IBS. And we test the two pharmacologically great fully human anti-PD-L1 blockade antibody, one already in the clinical development and one in the preclinical development. And we can tell the T cell can infiltrate the tumors in this model, and one infusion of the T cell can stay at least for 18 days. And we infuse the T cell, ex vivo active T cell, as well as the combination of the CD14 positive and the CD16 positive myeloid cells once every week, and also treat the mice with anti-PD-1 and anti-IL-8 blockade antibody. Interestingly, we see on top of T cell and anti-PD-1, and the myeloid cell, just the myeloid cell itself, instead of having immunosuppressive activity, can enhance the anti-tumor activity. Certainly with the anti-IL-8 antibody, they further enhance this anti-tumor activity. And we find this IL-8 blockade activity in enhancing the anti-PD-1 anti-tumor activity, mainly through targeting the CD16 positive myeloid cell, presumably is the granulocyte population. And we analyzed the tumor infiltrated immune cells in the tumor, harvest this mouse model following the treatment. And we find infusion of the myeloid cells can increase the intratumoral infiltration of the CD8 positive T cell. Again, suggest a potential immune enhancing effect, as you show in the panel C. And IOA blockade antibody increase the intratumor infiltration of the granulocytic myeloid cells, but not the monocytic myeloid cells. Okay, so now we're wondering, what is the mechanism of action of these myeloid cells? What is the mechanism of action of the anti-IL-8 blockade antibody? So we harvest the tumor following the treatment and perform the single nuclear RNA sequencing. And we are able to cluster the cells into tumor cells, myeloid cells, and T cell and the fibroblasts. We focus on the myeloid cell and T cell, which is a reconstituted and infiltrated tumor. And interesting, we see the IL-8 blocking antibody can potentiate the innate immune response in the myeloid cell population. This is represented by the enrichment of multiple neutrophil response pathway and the microbial infection response pathway as pointed here by the red arrows. And those genes that upregulate the tumor that are treated by the anti-IL-8 blocking antibody in combination with anti-PD-1 antibodies enriched with this pathway compared with the control IgG treated mice. Consistently, IL-8 blocking antibody also potentiated the type 1 cytokine response. As you can see, the green arrow point to the pathway of the type 1 cytokine response pathway that enriched in the genes that are upregulated in the tumor that are treated by the IL-8 blockade antibodies. And presumably as a result of this potentiation of the myeloid cell, and we also observe the enhancement of the T cell activation pathway in the tumor in the T cell clusters. So based on this rationale and the preclinical study, now we're adding a new arm to test the combination of anti-IL-8 blocking antibody and the nivolumab in the neoadjuvant setting. And we got the FDA approval recently and are going to enroll the first patient very soon. And thank you very much for your attention.
Great presentation. Now floor is open for question and I'll start. So you are looking for IL-8. You found that IL-8 is upregulated in the when you give anti-PD-1. But there is other checkpoint therapy. So this is very specific to anti-PD-1 or you see it for other checkpoint also?
Well, we only test, we only have a specimen with PD-1 checkpoint. Yes, it's specific for the group treated with a checkpoint, but not in the GVAS alone arm. Yeah.
Okay, thank you. Yeah.
Hi, Greg from Emory. Really exciting data. I'm wondering if you guys have seen modulation of CD40 and do you plan to do like a CD40 agonist given the single agent activity historically in pancreatic cancer with your IL-8?
Yeah, that's a very interesting question. So not in this particular study, but I have other study actually looking at the CD40 positive dendritic cell. Interesting actually is maybe limited by our tumor model. That is the KPC model. So we don't really see actually CD40 actually, positive dendritic cell. Maybe actually that suggests we're missing that CD40, but we don't really see actually any correlation of the CD40 actually dendritic cell actually in our response. That project actually is is treated with a STING agonist and ARP3 agonist, but you might be right actually it's the CD40 agonist. Maybe that's exactly what we're missing. Yeah.
Thank you.
You're welcome.
Thank you, Dr. Jang.
Yeah. Thank you.
So we come to our last presentation. It's also a video presentation, this time from India. Dr. Priyanka Sarkar from the Asian Institute of Gastroenterology will present a paper titled Next Generation Sequencing Based Evaluation Revealed Dysbiotic Microbiome in Waldorf Necrosis in Patients with Acute Pancreatitis.
Hello everyone, I'm Priyanka from Asian Institute of Gastroenterology, India. Today I'm presenting our work on next generation sequencing based evaluation using dysbiotic microbiome involved in necrosis in patients with acute pancreatitis. I'm starting this presentation with a question why we are interested in this study. As we all know that 20% of 80 patients develop moderate to severe pancreatitis with pancreatic necrosis, and a proportion of these patients develop infection. And their health continue to deteriorate even after having prolonged prophylactic antibiotics and drainage procedures. Also, you may ask us why we consider fungus in this study. To answer this, we are highlighting one of the systematic literature review, citing 10 articles from the different parts of the world. All these studies have pointed that even though use of prophylactic antibiotics are not recommended, in real life scenario, they are used rampantly and many times irrationally. And a subgroup of patients do not respond well in this prophylactic antibiotic treatment. So this raises the hypothesis that could these patients have any fungal infections, or the use of prolonged prophylactic antibiotics causes the dysbiosis in the microbiome profile of these patients, followed by worsening their health status. Keeping this hypothesis in mind, we have taken this methodology. Since it's an ongoing study, we have enrolled 76 patients till date. Here I am showing the data of 69 patients. So we have collected fluid samples, stool and blood samples, followed by DNA extraction, ITS1 based and NGS sequencing analysis, downstream analysis using CHIMES, SPSS and R. We further evaluated gut permeability using fatty acids binding protein as a marker. Also, we added healthy volunteers in this study to know how healthy microbiome looks like and later on to compare with our patients. Let's look into our patient details. We have 63 patients in MSEP category and 6 in SEP category from 4 regions of India, mostly eastern and southern part of the country. Etiology wise, our patients comes under ethanol and idiopathic group, followed by biliary with a mean age of 35 years. Let's look into our fluid microbiome. We found the presence of Ascomycota and Basidiomycota phyla in fluid with having 7 classes, 9 orders, 14 genera and 37 species. We also observed severity-specific microbiome composition with Aspergillus penicilloides and Nelsigia globosa in MSEP category, Aspergillus penicilloides and Aspergillus flavus in SEP category. Since WON is unlikely a region for primary growth of fungus, we evaluated the stool microbiome composition of the patients to study the host microbiome composition. Well, we could not find any significant differences in species richness between patients and healthy control groups, but we do observe more diversity, more fungal diversity in healthy control than our patient group. While talking about the marker fungal flora, we do observe more Aspergillus penicilloides in patients group than our healthy control. So till here, we observe the presence of fungome in fluid and dysbiotic microbiome in patients. Now, we question how fungi reach to the pancreas from gut. To answer this, we evaluated blood microbiome profiles to know whether any circulatory microbiome exists in these patients. Well, yes, we do find the presence of Aspergillus, Candida, and Cladosporium in the blood of these patients, hinting the translocation of these fungal flora from gut to the pancreas. Interestingly, when we cross-check the culture-based results, we found most of our volunteers comes under no growth category. And those who are found positive for microbial growth are only having E. coli, Klebsiella, Cytobacter in their blood, while 2 samples are having positive for Candida albicans. These results hint towards the presence of uncultured fungal flora in the patient's group. We further evaluated gut permeability using fatty acids binding protein as a marker. Contrarily, we found less concentration of FEBP in the patients than healthy group. If we see the etiological data, we have more patients in idiopathic categories. So we want to check whether any etiology-specific crosstalk exists between microbiome and gut-bacterial junction protein. So what we observed is in ethanolic group, we do observe 20 fungal flora interacting with FEBP, while 8 in idiopathic group. Although we need to evaluate further to have any conclusion on this aspect. As a take-home message, I wanted to forward our finding that our study revealed the presence of fungal flora in WN fluid with Aspergillus penicilloides as a core fungi in fluid, stool, and blood samples of the patients. Secondly, along with the proper usage of prophylactic antibiotic, we are asking a question: should antifungals be initiated to ameliorate the disease prognosis at the early stages? Although to answer this, we need to further study to understand the relation between fungal colonization in the WN fluid and disease severity, with adding in-depth knowledge on antifungal sensitivity of the different organisms. Well, I'm wrapping up my presentation by acknowledging Dr. Talukdar for conceiving this study, Dr. Srinivas for helping us with the patient's recruitment. I'm thankful to my institute and our funding agency, Wellcome Trust DBT, also APA, for giving us the opportunity to showcase our work. Thank you all for your patience hearing.
Thank you, Dr. Sarkar. The floor is open for any questions or comments. So how unexpected is this? So, I mean, I think the more we look for things, as you said, the cultures did not grow this, right? Because of course, cultures for fungi are not that easy. And you see Candida or you see Torulopsis or things of that sort, especially in patients who've received antibiotics for a long time. But the implication is that they're there, right? And that as we suppress other bacteria, those fungi are allowed to grow. So is it possible that it is really ubiquitous, that we have this fungi, you know, in many parts? Do you have any data on other infectious processes of the body, for example, other intra-abdominal abscesses? How common is it using this sophisticated technology to identify very small amounts of the presence of the fungi that we will find that fungi? We can't hear you.
Am I audible now?
Yes, now we can hear you.
Okay. So first of all, thank you for this question. When we talk about human gut microbiome, we oftenly talk about only bacteria in it. We do have healthy fungi or fungome in us, which is less explored. So when we are enrolling these patients, like you said that if we use more prophylactic antibiotics, there is a chances of developing any microbial or mycobial dysbiosis. But the data, we do not have data as per pancreatitis we have or for any other diseases, except few cultural data we do observe as a candida infections in pancreatitis. Also, this is a preliminary study, so based on the data we can comment is that that is the first approach where we can think of a new site or to treat, having antifungal at the early on stage of the diseases. But it's too early to tell, it's too early to have any conclusion on this aspect. But definitely this is a new, this will open new paradigm where we can at least think of antifungals in place of antibiotics for some of the patients which are not benefited for antibiotics uses.
Thank you.
I have a question. So you enrolled a patient from different parts of India, and we know that the cultural and eating behavior are very much different across the India. So how similar is their microbiome or microbiome, and do you think it is good to combine all of them together, because because of different eating behavior that could be different? So can you comment on that?
That's a very nice question, sir. Actually, we first of all, we take in patients from the different parts of the country, as I have shown in my slides. Also, we have taken a detailed, we have a questionnaire where we have taken a detailed observation of their different dietary habits and all. So far, microbiome concerned, India is still dealing with the bacteria, like bacterium in as a healthy volunteer. So we have a study where we have shown that how healthy tribal Indian gut microbiome showed, and also 3-4 studies by Dr. Yogesh Soche and group, where they have shown how healthy human Indian microbiome composition is. So while talking about microbiome, they have only explained bacteria, not fungus in it. So this is the first study, which is showing as we have enrolled, I have shown here data of 6 healthy volunteers, but we have enrolled 20 healthy volunteers so far to have, just to know how healthy microbiome looks like. Because since these are patients group, we should know how healthy microbiome look, then only we can comment on this patient's aspects.
Thank you.
Well, with this, we conclude our session. Thank you, everyone, for staying, and thank you for staying so late for us in India. Thank you.
Happy Diwali. Thank you, sir.